total extraperitoneal (TEP) approach avoids entering the peritoneal cavity. Hence, there is the theoretical advantage of less probability for visceral injury or incisional hernias. In addition, it avoids the problem of closure of the peritoneal flap. It is more difficult than TAP because the operative space is tight. Preoperative preparation, anesthesia considerations, patient position, and operating room setup are the same as those for TAP A3 component. Dissecting balloon should be used to do the initial dissection of the preperitoneal space, figure 2a, b, ca 2 cm incision is made just lateral and INFE rear to the umbilicus on the same side as the hernia. The muscle is retracted laterally so as to expose the posterior rectus fascia. Blunt dissection with the S retractors or finger opens the preperitoneal space. Figure 1b. The dissection of this space is facilitated by the use of a 3-component dissecting balloon. This is inserted into the space via the umbilical incision. The bulb insufflator device is used to expand the balloon. During the insufflation, the surgeon monitors the dissection process with the laparoscope, figures 2a and b. The expansion is gradual. It is important to have all the creases in the dissecting balloon flatten out. The balloon is desufflated and removed. The smaller stay balloon is then inserted, figure 2c, and filled with 40 ml of air. It is used to hold traction on the fascia by being retracted back and locked. This is attached to the CO2 insufflator, which is set to a pressure of 15 mm of mercury. The patient is placed in a slight Trendelenburg position to avoid external compression of the preperitoneal space by the abdominal viscera. The hernia spaces are examined. 2 5 trocars are placed in the midline inferior to the umbilicus, figure 1a. The first is 2 fingerbreadths above the pubic tubercle and the second 5 fingerbreadths above the pubic tubercle just below the camera port. Figure 3a. Right direct inguinal is identified in the area is cleared, figure 4. A right direct inguinal is identified and the area is cleared, figure 4. Pubic tubercle is identified and slight lateral dissection is continued until the obturator vein is visualized. Blunt dissection with laparoscopic Kittner is used to open the preperitoneal space. Small tears in the peritoneum should be repaired in order to prevent competing pneumoperitoneum. If this becomes problem ATIC, a Veress needle or 5 trocar can be placed in the peritoneal cavity to release the CO2 pressure. The spermatic cord is then skeletonized and the preperitoneal space dissected to the same extent as the tap. Although the orientation is different, the dissection and the mesh placement are similar to the tap. The mesh is cut to the size and shape shown in figure 5. It is then rolled and inserted under direct vision through the 10 trocar used for the camera. Figure 6. The mesh is unrolled and positioned in order to cover all 3 hernia areas, indirect, direct, and femoral, figure 7a. It may be tacked medially in place, as described in the TAP section, avoiding the danger points previously discussed, figure 7a. Alternatively, some surgeons prefer to use a fibrin-based glue to secure fixation, while others use no fixation. While relying upon the deflated peritoneum to anchor the mesh, the trocars are removed under direct vision. The CO2 is slowly vented such that the mesh does not move. The mesh and collapsing peritoneum are observed as the videoscope is removed. The final position of the mesh in the preperitoneal space is shown in figure 7a. The fascia is closed with absorbable interrupted suture. Skin is closed with subcuticular absorbable suture. The bladder catheter is removed. Prior to leaving the operating room, local anesthetic may be injected into the incision sites. instilled into the preperitoneal space to facilitate pain management. If the patient is able to void urine, then he is discharged the day of the surgery if there are no immediate complications. The patient is also advised not lift greater than 15 pounds, about 2 gallons of milk, for the first week. Return to work is dictated by pain tolerance. Many patients are back to work in 5 to 7 days.